I'd like to welcome everyone to our Facebook Live event today. Thanks for joining us. We really appreciate it. My name is Dr. Michael Wind. I'm a member of OrthoVirginia, hip and knee surgery specialist. I'm going to talk to you today about the SubV knee, a subvastus approach to knee replacement, which is complete muscle and tendon sparing approach to knee replacement. We feel that it offers some potential advantages to patients, and I'm excited to talk to you about this today. So we'll get into it. Just a little bit about myself. I began here at OrthoVirginia in 2009, so I've been in practice almost 16 years. It's gone by really fast. It doesn't feel like that long, but it's been a while. I do specialize pretty much in hip and knee replacement. That's all I do. I do a lot of hip and knee replacement, between around 800 to 1,000 a year, so I'm the highest volume joint replacement specialist in Central Virginia. I function in leadership role at OrthoVirginia. I'm on the Central Region Board of Directors for the Richmond region and also the State Board of Directors for the state of OrthoVirginia. And I'm the president of the Central Region, which is the Richmond region, what most of you would think of as OrthoVirginia. All of our offices here in the Richmond metro area. So a couple of things we want to talk about today. In order to understand the SubV knee and what we're trying to convey to you, we need to know a little bit about knee anatomy. We'll go through that briefly. We need to talk about some of the basics of knee replacement surgery. What is knee replacement surgery? And then we're going to talk about some of the different techniques and what could be advantageous to certain patients. So I'm excited to discuss this with you today and hopefully enhance your knowledge about knee replacement and some of the options that are out. So just a little bit about knee replacement. We think about joint replacement as having been around forever, and it really hasn't. It was only in 1968 that a Canadian surgeon, Dr. Gunston, who you see here on the screen, performed the first rudimentary knee replacement. It was very different than the knee replacements we commonly see, but this was the beginning of arthroplasty of the knee. The first modern knee replacement, which you recognize as a modern type knee replacement, was performed in New York Hospital for Special Surgery, just over 50 years ago. During that surgery, the patient stayed in the hospital almost a month afterwards. If you think about how far we've come with joint replacement, now patients are going home the same day of surgery. So in the past 50 years, we've come a long way, not only in implant development, but also in surgical techniques and the ability to get people up and moving quickly. Okay, a little bit about knee anatomy. When we talk about the knee, we're talking about two major bones and one minor bone. The major bones, the femur and the tibia, as you see here in the image. The femur being the bone on top, your thigh bone that comes down and forms the knee at the joint. The tibia is what you would consider to be your shin bone that, as it comes up, has articular surface and forms the knee. But the ends of your bones are covered with what we call articular cartilage or cushioning cartilage. There's also a medial lateral meniscus, which is a thick cartilage that goes around the inside and outside of each knee. And in addition to that, as you see in the image on the screen, there are multiple ligaments, and we try to preserve most of these ligaments as much as we can during knee replacement, so the knee will function as close to normal as possible. So what is knee arthritis? A lot of people ask this, and it's a great question. What you can see if you look at the images on the screen, under normal knee, you see the smooth white articular cartilage of a normal knee. This is good cushioning cartilage. This knee typically does not give pain. This is what a normal knee looks like. If you look at the adjacent image, what you see is multiple cracks and breakdown of that cartilage. And so in knee arthritis, what we're typically talking about is osteoarthritis. And osteoarthritis is a wear and tear condition. And the final common pathway is loss of that articular cartilage. And when the articular cartilage thins or is completely lost, you get bone-on-bone apposition of the knee, which results in pain and dysfunction. The knee will swell, the knee can become more stiff. Patients can have trouble with things such as walking. And so you get all of the symptoms that we think of when people come to see us for arthritic joint. If you look at the x-rays, it's important. A lot of people, when we say bone on bone, to understand what we're talking about, if you look under the x-ray that says healthy knee, what you'll see is the femur bone on the top, the femoral bone on the top, tibia down below, and you see a space between the two bones. That is actually not a real space. That is the articular cartilage. It just does not show up because it's not calcified. Now, if you look under the arthritic knee image, what you see is on the outside part of the knee, there's still that space, but the inside part of the knee in this particular patient, the knee is now bone on bone. There's loss of that cartilage. And so what you can see is the calcified bone rubbing against the calcified bone. This is what we see in a lot of patients who come in who are candidates for knee replacement. They have x-rays that show bone-to-bone contact or close bone-to-bone contact. And along with that, they're having symptoms such as pain, stiffness, swelling, other things that are impacting their quality of life. So what exactly is knee replacement? We talk about it a lot, but understanding exactly what we're doing with surgery is important for patients. So if you look here under the image on the left side of the screen, you see the before image showing an arthritic knee. The cartilage is missing. There's areas where there's a full thickness cartilage loss, and so that patient is having pain. When you look under the after image, what you see is that there's now a replacement in the knee. What we're doing with knee replacement, some people think that we're removing the entire joint. What we're really doing is a more resurfacing procedure. We're taking small amounts of bone, usually 8 to 10 millimeters of bone, off of the femur and tibia, and essentially putting a cap on each side of the joint. In between those metal caps, we have a plastic spacer, and that functions as a new cartilage. You can see this in the image on the right. There's a femoral cap or component. There's a tibial base plate, the flat component, and then intervening in that, there's a plastic spacer. So when we talk about knee replacement with patients, this is what we're talking about. It's more of a resurfacing of the knee. The ligaments on the outside of the knee we're leaving intact because we want the knee to function as normally as possible after the surgery, as close to the natural knee as possible. So what do the implants look like we use in knee replacement? This is some images so you can see exactly what it looks like. There is a femoral component and a tibial component. The curved component that you see on the top is the femoral component that basically cups the femur and goes onto the femur. You also see the tibial base plate that has the keel that comes down that bites into the bone and stabilizes the implant. And then the plastic spacer that locks into the tibial component between them functions as a new cartilage. And so this is an actual knee replacement implant. You can see image there, and that is how it functions in the knee. So we talk about the knee. We brought up this image earlier. This is a very rudimentary image of the knee. This is a very simplistic idea of knee anatomy. We'll look at what the knee actually looks like. So the knee, when we go in to operate on the knee, is not just 3 bones. The femur, the tibia, and the patella, which is the kneecap. The knee actually consists, what you mostly see is muscle and soft tissue. So let's talk a little bit about that. The main muscle function or motor of your knee is your quadriceps, which is the large muscle on the front of your thigh. You can see in the image here, there are several different parts to the quadriceps. There's the vastus medialis, there's the vastus lateralis, and all 4 of those muscle heads come down into one tendon called your quadriceps tendon that you can see in the image on your right that inserts on the patella or the kneecap. So this quadriceps mechanism is the main muscle strength of your knee. It's what allows you to straighten your knee. It's what allows you to climb stairs. And during knee replacement, we have to navigate how to get into the knee to perform the knee replacement. So that is the question. So the traditional approach for knee replacement has been what we call the medial parapatellar arthrotomy. Essentially, there's a black line that goes down around the kneecap. And so the incision is made through the quadriceps tendon, through part of the quadriceps muscle and around the kneecap. And essentially we divide the quadriceps into 2 halves and open it up. I have a model here. I'll show you. So what you can see is this is a knee without any of the muscle. But let's imagine for a second, there's muscle on both sides. With a traditional medial parapatellar approach, there's an incision that's made down the front of the knee. And then a cut is made into the quadriceps tendon along the side here. But then the muscle that is the vastus medialis that's attached to this is pulled to one side, and the rest of the muscle and the kneecap are pulled to the other side. So essentially we book open the quadriceps tendon and muscle in order to gain access into the knee joint and perform the replacement. Okay, so this is a medial parapatellar approach. What we're going to talk about with the SubV approach is coming under the muscle and lifting the muscle and the tendon as one unit to the side without the need to divide through the tendon and without the need to split the muscle and open it into 2 halves. So this is the traditional, the medial parapatellar approach that I was discussing. An incision is made through the quadriceps tendon and muscle. The quadriceps is moved into 2 parts, a medial part, an inside part, and an outside part, and the knee is open in that way. And this is probably how over 90% of knee replacements are performed. So the SubV option, it is named the SubV because it is a subvastus approach. You can see a black line on the anatomic image there. And instead of going through the quadriceps muscle in this case, we're going underneath the vastus medialis. So that's subvastus, under the vastus muscle. And we're going to lift the whole muscle and the tendon to the side. So this is what we call completely muscle and tendon sparing. There's no incision made through the quadriceps muscle. There's no incision made through the quadriceps tendon. We leave that completely intact so that at the end of the procedure, the muscle can be brought back into place and is ready to function immediately with no significant violation. So what are some of the potential advantages of the SubV knee approach? So one thing I want to make clear is that a SubV knee is still a knee replacement. We're still doing all of the removal of the arthritic bone. We're putting in the same implants. It is a knee replacement. The question is, how do we get into the knee in a minimally invasive way that hopefully offers some recovery advantages to the patient? So these are all potential advantages. Recovery from surgery is really different patient to patient. So we cannot guarantee any outcome for any surgery, but these are some of the trends that I've seen and that are documented in the literature that I think are potential advantages to considering a SubV approach versus a traditional medial parapatellar approach. And the first advantage is less pain. We're not making that incision through the quadriceps tendon. We're leaving the muscle and the tendon intact. If you think about it, I'm going to show you a model again. This is the model here. So if we make this cut in the tendon, at the end of the case, there's a cut that goes into the tendon and muscle around the kneecap here. It has to be repaired at the end. So this is sutured closed at the end of a traditional knee replacement. There's a suture line that goes through here. When the patient goes to bend his or her knee after surgery, there's a tendency to want to pull on that suture line. So when the patient is bending his or her knee in the recovery period, there's pulling through that suture line that I think can contribute to post-op pain. With the SubV approach, all of this is left intact and everything is just brought to the side. So when we bring it back, imagine there's not an incision through the tendon now. Now the knee can function much more normally without that incision through the tendon. Okay? So one potential advantage, I think, is a trend towards less pain with a SubV knee compared to a more traditional approach. On the next slide, I'm just going to let you know there is a actual surgical image, not from here, but more of an educational image from an educational website that I'm going to show you that shows a more traditional approach. So if anyone does not like seeing intraoperative images, maybe avoid that. So what you can see, this is again, this is a traditional approach. What you can see on the surgical image here is that there's incision through the tendon at the top of the knee, and the knee is being exposed by opening the knee into the quadriceps into two halves. Okay. If we can avoid doing this, if we can avoid doing what we're showing on the screen and instead come under the muscle and lift the muscle and tendon over as one unit, there is evidence, I've seen it in my practice, of improved quadriceps control and improved strength in the early postoperative period. For instance, most of the patients that have had a SubV knee are able in the recovery area after surgery to do a straight leg raise, which means lying on your back. The patient's able to keep the leg straight, lift it off the bed and back down, which utilizes the quadriceps. I think that there is an improvement in that ability for patients having a SubV knee versus a traditional knee replacement. Again, everything varies by patient, results vary by patient, but there's definitely a trend towards better strength, better ability to climb stairs, improved ambulation early on in the recovery period, I believe, with the subvastus approach. Okay, another advantage is I think there's a trend towards better range of motion. Again, for the same reason, there's not this incision through the tendon and muscle that the patient is having to navigate with therapy. And so the muscle and tendon are moving more as a natural unit. So I think there is a trend in patients with the subvastus approach towards better early range of motion as compared to a traditional knee replacement method. Another potential advantage is patellar stability. So if you think about when in a traditional approach, when the incision is made through the tendon here, I'll show this again. The incision is made through the tendon. At the end of the surgery, so the knee is open in a traditional approach in this way. At the end of the surgery, things are brought back together. There's a suture line placed along where the joint was open, the arthrotomy, we call it. If you were to get dehiscence, or if this were not to heal, what can happen is that the kneecap can become unstable. Okay, so the kneecap can start to slide to the side. Okay, that's patellar instability, and that is not something we want. It's a rare complication, but it's a possible complication. With the subvastus approach, there is no incision through the tendon or the muscle. And so it is much less likely to have an issue with the kneecap sliding to the side or completely dislocating, I believe, because you don't have to worry about dehiscence of your closure or opening or lack of healing of your closure. Okay, so another potential advantage of the SubV knee that I've seen is expedited recovery, quicker recovery, for all the reasons we listed above. I think people are able to participate in therapy earlier on more quickly. I think they're able to return to work and hobbies and activities more quickly. Again, results vary by patient, but I think there's a trend towards this. And I also think there's literature studies that demonstrate this earlier, people progressing quicker in the early post-operative period with the SubV approach versus a more traditional approach. So a couple of questions, and why wasn't everyone perform this? It is a little more technically demanding to do versus the traditional knee replacement, in my opinion. I think it can take a little bit more time surgically. We all as surgeons, we all tend to do what we're familiar with, and some people don't have as much exposure to this, and some surgeons just don't feel like the potential benefits outweigh the increased operative time and things of this nature. So everyone has reasons similar to why some surgeons may not prefer the anterior tendon hip versus posterior. I think there's advantages to doing the hips anteriorly, but there's differences of opinion among specialists. So some surgeons just don't subscribe to this method. So some people ask, well, who is a candidate for a SubV knee? Really anyone who's having a primary knee replacement. With regard to revisions, there's a lot of scar tissue doing a replacement for a second time. Probably not the best candidate for a SubV knee replacement. If there's past hardware, say a patient's had fracture and we have to get to hardware past plates and screws to remove, may not be the best time for a SubV knee replacement. Another issue is if the patient has extreme stiffness. So the patient, for instance, cannot extend the knee past 5 degrees, cannot flex past 90. Sometimes the muscle can be so stiff, it's hard to mobilize it, and that patient may be better served with a traditional knee replacement. So what are some of the recovery goals after SubV knee? We want your pain controlled after surgery. We're hoping that patients, our goals is to be able to perform a straight leg raise immediately after surgery, to be able to get up and walk after surgery. Most of these surgeries are being done at our outpatient surgery center, so people are having surgery, going home later that day, discharge home within a few hours. We're hoping for patients to be off the walker within several days. Again, results vary from patient to patient. We're hoping to see more rapid progress with PT and returning to work more quickly. Okay, so we're gonna play this, it's a couple minute video showing some patients who we've asked if it's okay to show their images after having a SubV knee replacement in the recovery area and also in the clinic. So we'll go through that and then we'll wrap up and have some time for question and answer. We're here with Ms. Robotic, who is about 1 hour out from minimally invasive left SubV knee replacement using the subvastus approach. And how are you feeling, Ms. Robotic, with regard to pain?
I'm feeling fine on a scale of 1 to 10, maybe a 2.
Okay. Are you able to lift the leg straight up? Good. So able to do a straight leg raise. Excellent. Excellent. Well, it looks like you're doing great. We really appreciate it. And we'll try to get some videos of you up and walking and doing the stairs in a little bit.
Thank you.
So I'm here today with Mr. Grogan. He's about an hour out from a right SubV total knee replacement. So just how are you feeling?
I feel good, just a little uncomfortable.
Gotcha. Is your pain pretty well controlled?
Yes, absolutely.
Okay. And let's see if you can lift the leg straight up. Okay. No problems with that?
No.
That's great. So we'll see how you do when we get you up and walking in just a few minutes, okay? Here's Mr. Grogan, 1 hour out from his SubV knee. Walking is great. We are about 45 minutes out of surgery. We just did a subvastus left total knee. How are we feeling?
Great.
How was the pain?
3.
Okay.
Are you able to lift that leg straight up? Perfect.
I have Mr. Fisher here, who is 2 weeks post-op from his left total knee replacement through the subvastus approach, and he is doing extremely well. Mr. Fisher, how would you say you're doing at your 2-week mark?
Great.
Yeah, and
Better than the last one.
and that's great. And you had your last one done a couple months ago, correct? And how's physical therapy going so far?
Excellent.
Good. And how would you say your pain is at the 2-week mark?
Probably about 2.
Okay, great.
It's more irritation.
Okay. That is great to hear. Well, let me have you lay back if you can, and you can just show me how your range of motion is doing so far.
All right.
So this is at 2 weeks, and he can get his leg almost completely straight, and then he's able to bend it up quite a bit at this point. He's also able to do a straight leg raise at this point. If you can just show us how you're able to do that. So go ahead and bend straight up. Perfect. Very good. All right. And you can go ahead and sit back up for me. And he is already at the point that he's able to walk with just a cane. And you said you were able to go to a cane how quickly after surgery?
2 days after the surgery. I was using a walker before that.
Okay. That is great. Overall, pleased with your experience at the Outpatient Surgery Center, and that is great. All right. Well, thank you very much.
Thank you.
Those are 3 patients that underwent SubV knee replacement. You saw some of the recovery in the post-op area, and then how they were doing therapy. All those patients were able to go home the same day. Just a couple things. So how SubV knee is performed throughout the country. In Richmond, the exact prevalence unclear. Probably 5 to 10% of knee replacements are now done subvastus or SubV, but I think the percentage is growing. Okay, so as I said, most of these are done outpatient. Outpatient joint replacement surgery is growing in prevalence. I do most of my joint replacement outpatient, which is a market change from where we were several years ago. I think outpatient joint replacement is a great option for patients who are candidates getting back to recovering more quickly, getting back to activity. I think is all enhanced by being able to go home and getting up and going soon after surgery. We at OrthoVirginia, we perform outpatient joint replacement at 2 facilities. Our brand new Westchester facility, which has a great OR, great surgery center setup, and our Boulders Ambulatory Surgery Center, which is an HCA OrthoVirginia joint venture at our Boulders office complex. Why do I think that patients should consider or choose SubV? I think it's a completely muscle and tendon sparing approach. I think it's the most minimally invasive approach for knee replacement. I think the potential benefits to this are it's less pain, less invasive, better strength, improved range of motion, and hopefully quicker recovery, getting you back to enjoy life and doing the things you want to do. So thank you very much. And I am happy to answer questions. I think Margaret, our moderator, is going to hop on and we'll try to answer questions.
Yes, thank you so much, Dr. Nguyen. I first want to mention that we will be answering questions submitted earlier and questions submitted live. We have lots of great questions. So not all questions will be able to be answered, but we will do as many as we have time for. So our first question is, how quickly can I return to work after the SubV knee replacement?
So, that's a great question. I think that a lot of it depends on the job you do. So returning to office work is a lot easier than returning to work that might involve climbing ladders or more manual type work. Results vary from patient to patient, but in general, I've seen a lot of people who are doing office-based work back to work within a couple of weeks after surgery. So most of these are done outpatient. People have surgery, usually home within a couple hours. A lot of those patients are back at office-based work within a couple of weeks.
Thank you. What is the recovery process like with a SubV knee compared with a traditional knee replacement? When can you walk? Can you climb stairs? And how long does it take to do physical therapy?
So with the SubV knee, I think that in general, each step is a little quicker than with traditional knee for most patients. We have patients up and walking the day of surgery. So patients are doing, usually within an hour or two of surgery, we have patients up and walking, as you saw in the video. Again, I apologize about the audio and that, but patients are up and walking really right after surgery. We do stairs in the surgery center after surgery. So patients are trained on climbing stairs, are able to climb stairs. One of the criteria for going home the same day is being able to climb stairs. So patients are able to do that. And most patients, I would say, are in PT twice a week for anywhere from 6 to 8 weeks. A lot of it can be handled at home on your own if you're willing to do the exercises and work hard at home on your own. So therapist sort of coaching a patient and the patient working, doing daily exercises at home can be very effective.
Thank you. What's the difference between a SubV knee and the Jiffy Knee?
Yeah, I mean, that's a question. That's a great question. A question I get a lot from patients. Just to try to answer it fairly, I don't know really what the Jiffy Knee is. OrthoVirginia has no affiliation with anything regarding the Jiffy Knee. I know from patients that there are a group of surgeons that say they do a Jiffy Knee. I did a literature search on PubMed, which is the search engine for the U.S. Department of Health, and there's no peer-reviewed articles. There's no information at all in peer-reviewed journals about the Jiffy Knee. Because I've gotten so many patient questions, I've gone to the website and looked at it. From what I can tell, they're just doing a subvastus knee replacement. Basically, they're not cutting the muscle or the tendon. It looks like they're coming underneath the muscle. But again, because there's nothing published about it in any of the major journals, it's hard to know. But from what I can tell, it appears that they're performing a subvastus knee replacement as well, based on the available data in the market.
Thank you. Is the subvastus approach covered by insurance?
Yeah, another good question people ask a lot about. It absolutely is. This procedure would be billed as a total knee, whether done traditional or subvastus. So it's a technique similar to anterior versus posterior to the lip. For insurance, there's no difference, no increased cost. If your insurance covers you for a total knee, the insurance doesn't care whether it's done through a SubV approach or a more traditional approach. So no added cost, no change in the procedure coding or billing. So patients don't have to worry about that.
Are there any age restrictions with it?
No. So there's no age restrictions. Patients could be a SubV candidate who are younger patients with knee arthritis or older. I would say the real restriction is, as I talked about on the slides, it's really the range of motion. So when patients have really stiff knees, it can be difficult to mobilize that quadricep and get it to slide out of the way. And in those cases, sometimes you might do more damage to the muscle trying to slide it out of the way versus just doing a traditional arthrotomy. That's really the main limitation. That revision surgery is not a good situation for it due to the scarring or past trauma. Again, as I mentioned, where there's hardware that has to be removed, where we might need to get to certain areas of the knee that SubV wouldn't allow us to do. But for most patients with reasonable knee range of motion who need a knee replacement, they would be a candidate. There would be no real age restrictions on it.
Can you do both knees in the same surgery?
You certainly can. So bilateral knee replacement is possible. I've done it for patients. I've had that discussion actually twice this morning with patients. But my general feeling, I will tell you, my general feeling is that patients do better doing one knee at a time. That's my experience, 16 years doing a lot of joint replacement. So the path I generally try to steer patients on is having one knee fixed, getting some strength back in that knee, and then potentially doing the other knee. Sometimes we'll do them, 7-8 weeks apart. So we don't have to wait a super long time. Patients are making recovery, we'll go ahead and get the other knee fixed. But I feel that patients do better, in my opinion, doing one knee, focusing on recovery of that knee, and then moving to the next knee.
Is there any difference with the type of hardware, implants, or any components that you put in the body with a subvastus approach compared to a traditional approach?
No, there's no difference at all. So the actual implants, we make the little cuts on the bone, all that's the same. What we're really talking about is how do we get into the knee in potentially a more minimally invasive fashion, and the potential for that to expedite recovery. But as far as the implants we utilize, As far as what we do to the bone itself, that's all the same once we get the knee exposed.
Can this approach be used for a partial knee replacement or only for total knee replacement?
I can absolutely be used in partial knee replacement. So it's a great option for it with, say a patient is having a medial, which is the most common partial knee replacement, medial unicompartmental knee. You could do that to the SubV knee, no problem. So it would be an option with partial knee replacement surgery.
Are there any restrictions after surgery while you're recovering, or long-term restrictions even after you've recovered?
No, with knee replacement, with the SubV knee, we would allow you to progress as tolerated. So patients can progress their walking, progress their strengthening, progress their activities, progress return to work, all of that really as they tolerated. The most specific restrictions that we would give to patients. Obviously, in the immediate post-op period, patients are going to be out running and doing things like that. There's a recovery process. But as far as can I climb stairs? Can I walk a certain distance? Can I participate in all aspects of physical therapy? There's no real restrictions. We let people progress as they're able.
Is the patella also replaced?
Another good question. It depends on the status of the patella. I would say in the knee replacements I do, I resurface. So we don't take the whole patella out. If the patella is arthritic, if it's a lot of cartilage loss, you can resurface, which means take off the arthritic part of the bone and usually put a plastic backing on the patella. I would say I do that in about 75% of the knee replacements I perform. And the other 25%, the patella looks great. And so if the patella has great cartilage and there's no obvious pathology, then I'll leave it. But I probably resurface the patella in about 75% of knee replacement and retain it in about 25%.
How do I tell if my surgeon does the subvastus approach? And if they do it, is that something that is decided ahead of time or something that is decided on the day of surgery?
So a lot of times with patients, I'll speak with them when we're having a preoperative consultation about the option. There are times where I will tell the patients we have to see how tight things are in the knee. And so we would open the knee, and if it didn't look like a situation where we could do a subvastus, we would do a more traditional approach. I usually try to talk to patients ahead of time as much as possible. But in the end, I try to do a SubV knee on everyone who's a good candidate for it, because I do think there's advantages to it as far as recovery. But there are some people, as we mentioned, that are not great candidates for it. And so those patients may do better with a more traditional approach. But in the end, I think it's important, whether you're coming to see me or another surgeon, to ask that surgeon's opinion and get an expert opinion on whether or not this would be a good procedure for you.
Are robotics used?
So you can use robotics in conjunction with knee replacement. I've used, during my career, the Mako platform. I've used the Mako robot. I've used the Rosa robot. Me personally, I don't love the robotic platforms. I use it intermittently when I need to for more complex cases, or the cases that have issues where it may be beneficial. But in a general sense, I don't use the robot routinely. You certainly can use the robot in conjunction with it. So the robot part is what's dealing with making the incisions on the bone, the cuts on the bone. And as I said, that's the same no matter whether you did the SubV approach or a more traditional approach. So you certainly can use the robot, or you cannot use the robot with this.
How long does the knee replacement last?
We're hoping that the implants that we are currently using are better than the ones we had 15, 20 years ago. I think the implant companies have made progressive improvements on the polyethylene and the way we fix the implants to the bone. I tell patients that I'm hoping the implants last 20 plus years. That's what we're hoping. I'm hoping it's longer than that. There's not a guarantee on that, but we're hoping that these implants last decades at this point.
Is the ACL spared using this approach?
The ACL is not spared with any major knee replacement system on the market right now. So pretty much in every knee replacement system, the ACL is sacrificed. Honestly, and most people who have severe arthritis, when you expose the knee, you realize the ACL is diseased and many times completely absent anyway, just due to the arthritis and the chronic changes in the way the knee works. But no, you would sacrifice the ACL in pretty much any knee replacement system, including the SubV.
What kind of anesthesia or pain relief is used?
That's a great question. So at our outpatient surgery, you can do the knee replacement through a spinal block or through general anesthesia. At our outpatient surgery centers, we focus really on a light general anesthesia, usually not require intubation, just a mask that's put in the mouth during surgery. One of the key aspects that we do at our outpatient surgery centers is preoperative blocks. So before surgery, the anesthesiologist will visit with the patient in the pre-op area, give some light sedation, and then use ultrasound to identify the major nerve structures around the knee and do multiple blocks to help with post-operative pain. And that's been really effective in helping our patients get up and get going in the outpatient setting. So we see a lot of patients who are up and moving with relatively little pain within an hour of surgery. Whereas if I look back 15 years ago to how things were, it was markedly different. So I think the anesthesia techniques and working with a great anesthesia team, which we have, has been really helpful, especially in the outpatient surgery center setting.
Are there restrictions for having the surgery related to BMI?
Sure. So BMI refers to patient's height and weight as body mass index. We generally, as a general rule, we try to counsel patients to get their BMI under 40 before elective joint replacement, both hip and knee. There's times where there's exceptions to this, but we feel like that it helps reduce patient risk. Really, that's the major restriction we have, is trying to get people to a body weight where the risk of complications is lower. With regard to the subvastus approach, I will say elevated BMI probably makes it a little more challenging, but I've done it in people with BMIs in the upper 30s and it's been fine. So I would say there's a general BMI cutoff of around 40 for all joint replacement in my practice, and across OrthoVirginia, we try to do that, but not specifically a cutoff for the SubV.
How long after a SubV knee replacement can somebody start driving?
Yeah, so I would say most of our patients, some of it depends on what knee you're having done. Most of us drive primarily with our right leg. So recovery from driving is probably a little quicker if you're having a left knee done. But in general, most people are able to drive around 10 to 14 days. We always tell patients you should not be taking narcotic pain medicine when you're driving. And you should never drive until you feel comfortable for your safety and the safety of other motorists. But I would say our average patient we're seeing is back to being able to drive in around 10 to 14 days.
Thank you all so much for your questions. That is all the time that we have for questions. Dr. Wend, would you like to close?
Yeah, well, I'd just like to thank everyone for joining us. We appreciate your time and learning about this. We want to try to educate patients on all the options that are out there. Myself and my partners at OrthoVirginia are happy to see all patients for any musculoskeletal problems. So if you would like to be seen, please visit us at orthovirginia.com and go to appointments. We're happy to see you and we appreciate your time today. Thank you very much.